before we dive into exactly how should I contour this, I think it's important to reflect a little bit, take a step back, and really think of contouring as a skill. And when you combine passion and skill together, then you get a masterpiece. So what are the skills in contouring? Recognizing your skills will help you grow as a physician. And we've been thinking about this a lot over the past couple months, and we've distilled it to 4 skills that exist in contouring. One is kind of our ancient skill as radiologists, and that's being able to distinguish gross disease on imaging. You get better with this with practice, but there are also tips that you can do to improve your ability to do this, which Jon will get into a little bit. The second very important skill is using other additional available information efficiently. So what does that mean? You're looking at your computer screen, you have a CT simulation scan. Are you ready to just start contouring? The expert contourer will know in their mind what are all the other things that they need to think about, that they need to look up, or that they need to review before they start contouring the first thing, to know that they are contouring the target exactly as they need to. Because sometimes there's information outside of the CT simulation scan that influences what you need to contour. And learning how to do that efficiently and knowing exactly what to look for every kind of cancer is a skill. The third skill, and this is probably the one that people think about the most, is the actual contouring of the anatomic volumes and the expansions. CTVs, ITVs, PTVs. And then lastly, applying contouring tools, resources, and mental tricks. So these are things that don't exist in the patient chart. These are things that you know about, that you're resourceful, or that you've learned from others, from mentors, from training courses. And so learning how to apply those is a skill. And if you combine these 4 things together, you'll be very powerful contouring. And actually, contouring may start to seem very easy. So I think I'm saying the obvious because we're all radiation oncologists, but these little details really do matter. And especially as we transition from 3D to IMRT and VMAT, the accuracy of our contours becomes more important than ever before. It is very easy to miss things or make small mistakes without even realizing it, especially when you're on your own and you don't have many colleagues around you to provide constant peer review. So we're going to try to help you avoid small common mistakes. And we know that if you are able to achieve better contouring, you will achieve better outcomes for your patients. Treatments will be easier, will be more tolerable, likely with less toxicities, and patients can have better long-term results. And we also know this not just from anecdotes, but from reviews of phase 3 trials, where people have actually compared the quality of plans that were submitted and found worse outcomes when there were deviations from the contours that were supposed to be done. So let's take this step and improve cancer outcomes for our region. Our first skill set is recognizing gross disease on imaging, and I'll hand off to Dr. Paly.
All right, thank you so much, Ben. A great introduction. I'm just going to pull up my presentation here. All right. Everyone able to see this okay? Ben, are you able to see my screen here?
Not yet.
Not yet.
Oh, okay. Let me try.
Make sure on Zoom you click share screen. Okay.
All right. How about now?
It looks pretty good. It doesn't look like it's in presenter view.
Looks good. Should I go ahead?
Yeah, try clicking the advanced. Yeah, it looks good.
Okay. All right. Thanks for bearing with us, everyone, while we got our technical challenges through. So again, my name is Jon Paly. I'm a radiation oncologist at Massachusetts General Hospital in Boston. I'm very honored to be speaking to you today. Thanks for coming to spend part of your weekend with us. I think this will be an interesting session. So today is really an introduction meant to cover general themes on the topic of target contouring. And I appreciate that much of this information is likely to be obvious to many attendees, but we feel it's important to cover some of the common contouring techniques and tips across all disease sites. So we'll take it away. And before we really dive into contouring, I do want to take a step back and talk about the importance of simulating your patient correctly and setting yourself up for success by performing an appropriate planning simulation before you start contouring. And so some notes about simulation. The first thing I think that's important to discuss is that when it's both advantageous and available at your institution, we like to do CT simulations with IV contrast for better target and soft tissue delineation. Now, there are certain disease sites, of course, like head and neck and lung, GI, definitive GYN or sarcoma, lymphoma, that benefit more from having IV contrast, whereas other disease sites such as CNS, where we prefer MRIs, or breast, or a lot of GU or skin cancers, IV contrast really doesn't add a benefit. And then adding another topic on simulating for success in areas of the body where you have a moving target, we like to do a 4D CT as we have in this animation here for a lung tumor. Certainly thoracic tumors or upper GI cancers benefit greatly from this if it's available. So now that we've done our radiation planning scan, it's important to incorporate and look at the prior imaging that we have in order to set ourselves up for the best possible outcome in our contours. And so image registration is really key to these accurate contours. We want to apply an image registration or image fusion of prior diagnostic scans like MRI, contrasted CT, or a PET CT. And we don't want to look at these side by side. We want them overlaid on each other because the former method is somewhat error prone. So instead, as we're going to be talking about more, it's important to import your prior imaging, perform an image registration, and adjust as it's needed to make sure that the fusion looks good. In this picture here on the bottom left, I have a nasopharyngeal case where I've fused a PET scan to the planning CT. And I kind of would ask rhetorically, why does it look like some of this scan is misregistered? Here we have the mouth that looks totally off, okay? The answer would be that we're doing these fusions based on the area that we're interested in contouring. And so if the base of the skull is the site that we're most concerned about, that's where we can do our fusion based off of. Whereas alternatively over here, we have the neck where we've done a fusion to align better to the neck nodal levels.
And Jonathan, can I pause you here?
Yeah.
So if I'm understanding correctly, does this mean that when you tried to do the registration in the beginning, it does an automatic registration? And does it automatically register how we want it, or how can you tell if it's right and if you need to adjust it?
Yeah, great question, Ben. I mean, automatic registrations are gonna look at the patient as a whole, and in this case, I suspect they would be fairly off. And so what we want to use is a region of interest. We'll usually draw a box, depending on what software you have, draw a box around the area of interest and make the fusion based off of that. And in this case, as I'm going to talk about later, I've actually done two fusions, one based off the skull base and another based off the area in the lower neck so that we have better alignment of the structures that we want. So we're not going to be talking a lot about organs at risk, but I do think it's worth pointing out a strategy that has worked well for me and many people who have been my mentors, and that's just that doing the contouring the organs at risk before the targets is often advisable. And so you might ask why. I think that this does help with cropping out the eventual clinical target volume without having to jump back and forth between the target and the organ at risk and just having it done first. I think it helps especially when you're contouring luminal structures or tubular structures, like in the pelvis, where you have vessels next to bowel or esophagus next to vessels in the mediastinum. And also on a personal note, I think it saves the most interesting part for last, because I think the targets are, of course, the more fun than contouring small bowel and lots of other OA. So we'll start off with the concept of the gross tumor volume. I'm sure everybody here knows this, but just as a very basic recap, our GTV can be either primary tumor or involve lymph nodes that are present. And here we have a slice in the pelvis showing a large pelvic mass that's abutting the bowel. And we've decided based on our imaging and our exam that this disease does not invade the bowel, the rectum. And so we're contouring the GTV based on the fascial planes here and not expanding it into the rectum here, which we feel is uninvolved. Another important key when contouring targets is to use the appropriate window level to distinguish anatomy in different parts of the body. We don't want to contour in only one window level. This will give us a hard time outlining the more anatomic boundaries, okay? I think this is especially important when you have a contour that's abutting bone, as bone can look very different on at different levels of windowing or contrast, or in this case, in a lung. This is another lung tumor where we can see that the same exact tumor, when windowed differently, looks very, very different, and you would massively under contour this if you were to only look at it in the mediastinal window. Another really important key is to look at everything, to look at your contours in multiple views. Of course, as radiation oncologists, we do our contouring in the axial view, and that's the easiest. But it is important to check those contours and use the other anatomic views to assist you. So we'll want to look, this is especially helpful when, when a tumor is abutting linear structures such as pulmonary vessels in the lung fissures, or bowel. So you'll note here in this picture, actually, where I've contoured the GTV, that there is actually this medial area that looks like it could, can you guys see my mouse okay? Yeah, so you can see this medial area here that looks concerning for, possible creeping of tumor. But now when you look over here in the coronal view, you can actually see that this in fact is a vessel, is a linear structure, and is not related to the tumor. And so you've saved over contouring here because of looking at these different views. Similarly up here, you can see a kind of this puckering and a fissure that's not involved with tumor. Another important thing that's always been helpful for me is the idea of choosing an anatomic plane and boundary and sticking with it rather than jumping around from slice to slice when contouring. And this applies to both your gross tumor volume and the clinical target volume when you're contouring. So here, I have an example of a head and neck case where we're contouring level 2 with the retropharyngeal nodes. And up here in the left, you can see I've outlined the things correctly. The CTV goes down here, abutting the medial side of the sternocleidomastoid muscle. Alternatively, here, another common mistake that people sometimes make is instead of drawing the tumor volume to be out by the sternocleidomastoid, it comes in deeper behind the levator scapula muscle, where there are not any lymph nodes to worry about. But eventually, as you kept contouring, that you would get to here. This is further down the neck and the correct contour again. So obviously, we're not going to want to jump from this image to this image. So being consistent and making sure that you're not hopping between anatomic planes as you're contouring is certainly important. This can also be helpful if you have artifact at one level and you can look at planes above and below where that artifact is, or something's obscured. Contouring above and below can help you then know in the middle where the correct contour is. This is another example in here where I'm using a GTV in the head and neck. And so this is a tongue-based tumor starting on the left and going down or inferiorly from left to right and then across here. You can see that I'm drawing a GTV based on an IV contrast scan and also a PET scan, which had been fused. And you can see that as I'm progressing, you can see the outline here of the area of gross tumor, but in this slice, there's some artifact And you know, I've kind of taken a little bit too much liberty contouring the soft palate or tongue base here, and it doesn't really fit with what I've contoured in these other slides over here. So obviously this slice is wrong, and so we've kind of failed to maintain a uniform expansion across our uniform boundaries as we've continued to contour. And if you were to look at this slice in a coronal view, you would see, you know, one slice sticking out in a jagged format, which would let you know something was amiss there.
Mhm. And John, I think that's a great point on the last slide, that when you're contouring gross disease, focus on the slices where you have high certainty. Focus on the slices where you feel like you really see it well, rather than having some slices that are tricky and trying to guess, because you'll probably be better off by doing the slices that you know are correct and then interpolating rather than guessing on the slices in between.
Exactly. Very well said, Ben. And this is, yeah, anywhere there's artifact in the pelvis or in the head and neck, it's especially true.
And we have a good question from Julie Jamnasi from Indonesia. Thanks, Dr. Lee and Dr. Paly, for IV contrast. Wouldn't it be better to do IV contrast to post-op gyne and GI to identify lymph nodes? And then whether or not to extend to PAN. And I'm not sure I know what PAN stands for, but if someone in the audience knows what that stands for and can type it in the chat, oh, that would be great. Para-aortic, okay. Thank you so much.
Very good question. Yeah, so in a post-op pelvic case, for example, for GYN, if we're not especially concerned about there being, you know, leftover nodes and they've had a diagnostic scan, for our treatment planning scan, we're really just contouring the vessels. And so typically I would just use like a non-contrast scan for that. Same with the rectal, if it was a post-op rectal. If you were doing something in the upper GI, I think, yes, it would be much better to have, even post-op, to have IV contrast so that you could see vessels like the SMA or the celiac or things like that. So just by way of kind of making some examples for IV contrast being helpful for certain sites, but not others. And if you have it, you know, to use it. Great question. All right, so the next topic is going to be using other information efficiently. And this really brought to mind a favorite quote of mine, which is from an American president, Abraham Lincoln, that I think runs true here as in many places, which is that, you know, if you were to say that you had 6 hours to chop down a tree, I would spend the first 4 hours sharpening the axe, meaning the most important thing is gathering the data, setting yourself up with the right information for success. If you have all of the information you need, you know what you're going to do, you know what expansions and to use and what areas to contour, it will make the actual contouring much easier, and you'll be much less likely to go back afterward to try to figure out what's going on. So always good to start with that. So let's start sharpening that axe. And the way that I do that typically is by starting with the operative note before I start contouring. So the surgical and endoscopic examination reports can really be vital. You want to see what the surgeon potentially struggled to clear, for example, during any part of their case. Sometimes you may not have spoken to the surgeon, or surgeons may sometimes not want to admit that they left disease behind, but they may be kind of cryptically telling you in their operative note what happened. And so these are some things that I've pulled out of operative notes that I think are very telling. You know, lines like tumor was adherent to X vessel or nerve, and this nerve was spared, like the facial nerve or a celiac artery or something like that. Or a piecemeal resection was performed, or a near complete resection was performed, or a small shelf of tumor was left along something. All of these are saying the same thing, which is that the surgeon did not clear the disease, and that area requires, you know, extra care and extra attention, certainly, and maybe a higher dose. Tumors in luminal structures, generally GI structures, are described more in endoscopy reports. And so esophagus, stomach, rectum, anus, It's important to look at the endoscopy reports and look for the descriptions of the distance from either the anus, if it's a lower GI, or if it's esophagus, from the incisors, to know how far down they encountered the tumor, which may not show up on imaging. And then we want to take that information and compare it to the pathology report. And so you've probably already looked at the pathology report when you staged the patient or decided to treat. But I always take a look at this again right before I'm contouring. I read the whole thing. Sometimes you will notice surprises or things that weren't brought up by anything else. For example, are there any positive margins or close margins? And if so, what side were those positive or close margins on? And were there positive nodes? And if so, what lateral, what side were they on? And what nodal group or level? Was there any extranodal extension or lymphovascular invasion or perineural invasion? And if there was perineural invasion, was it microscopic or was it gross perineural invasion? You know, all of these are very telling and will shape what you are drawing.
And John, on that last slide, just in case it's not obvious, why do you care about what side the positive margins were on?
Certainly, I mean, if you're taking something to a higher dose in order to cover a positive margin, you want to know which side of the specimen you should be contouring that on. You know, you're probably not going to see gross tumor on the imaging, so you may be operating a little bit blind by just deciding the left side of this cavity is now going to need to get this higher dose in order to account for that positive margin.
Yeah, and the same thing for LVI or PNI or ENE.
Yeah, and there's all sorts of shades of gray. One millimeter of ENE is not equivalent to gross ENE stuck to the side of a muscle. And so all of these things need to be taken in context, certainly.
Great, thank you.
Yeah, good question. So next, using physical exams to inform your contouring. I think this is really important, and I always encourage people to perform their own physical exam. You will be the one contouring the patient, responsible for the patient, and so you should be the one to evaluate things as best you can before doing that contouring. So it's best to perform direct visualization with, say, a nasopharyngeal laryngoscopy or an oral exam, if possible, or palpation, doing a cervical exam with a pelvic exam, or a digital rectal exam for an anal or rectal cancer to confirm what you're doing. If you're unable to do this for whatever reason, then of course, reviewing somebody's notes or calling them is the next best step, but I always try to do it yourself. For any tumors that are close to nerves, especially in the head and neck region or in the brain, you want to remember to look for subtle signs of nerve deficits or nerve involvement that very well may be invisible on imaging, certainly on a CAT scan. All right, so we're going to take a break here for our second Zoom poll before we dive into image registration. Ben, are you able to pull the poll up, or can I? Let's see.
Yep.
There we go. Great. So we're interested to know how everyone performs image registration and fusion at their center.
Or if you don't perform image registration.
If you don't at all.
And, you know, I know that there's different levels of technology and staffing. And so this actually really helps give us a better sense of how we can best teach and cater the educational materials for you all. Okay, good. We have 100 people who have answered. This is really good. We'll give maybe 10 more seconds. And then, John, there's a question in the chat that's related to this, which maybe we can talk afterwards, but it says, this is from Riz Rayo from the Philippines. Good morning. I would like to ask if you can contour directly on contrast-enhanced images, or do you still do it on the plane scans? So, I mean, what a perfect time to ask this question, because I think it's actually quite related to image registration. So, okay, we'll close this Zoom poll in 5, 4, 3, 2, 1. Okay, and then here are the results for everyone. So take a look. Good. So it looks like 72% say yes, they independently perform it. So that means about 30% don't do it personally. And so if you're at a center where you have some colleagues who do it, but you don't do it personally, this is a great thing that you can learn, that you can ask them to show you how to do it, because this will improve your ability to contour well. And if you don't do it at your center but are interested to learn how, please feel free to send us an email. And then, yeah, maybe we can revisit the question. So would you contour directly on contrast enhanced images, or you just contour on the plane scans? So I think the next slide will actually show us a little bit about what are some different approaches for using different image together. And Umi's question. Oh, Umi has one question. What does registration mean? Registration is linking the images, and then you can adjust the registration so that it looks exactly how you want it. Fusion is actually visually how it looks. So registration is the process, and then fusion is how the image looks after you've done that process. And you can toggle the fusion, so you can go from CT to MRI, or from CT sim without contrast to your diagnostic CT with contrast.
And I think to touch on the other question, I suspect what they're referring to is, do we worry about contouring on a contrasted scan and having the altered densities in that scan affect the radiation planning process as far as the Hounsfield units being different? So that's a very good question, and one that I've asked physicists several times. The answer that I've gotten is that when we've tested this and we look at the differences in planning on a contrasted scan, say in the head and neck or the thorax compared to a non-contrasted scan, that there is less than a 1% difference in dose absorption. So that it's very small. It's not zero, but it's small enough that we typically don't need to contour on another scan. Now, sometimes if there is a really bright area in, say, the inferior vena cava that's very full of contrast, it is important to have your dosimetrist or you contour that area and set it to the blood pool Hounsfield unit to make sure that you're not tricking it into thinking it's something denser. But in general, the slight differences in contrast will not affect planning in a significant way. Very good question, if that's what the question was. I think
yes,
it was.
Great.
All right. I'm going to move forward here. So, bringing us into a similar topic, which is, using prior imaging in addition to your CT simulation. It's important, first things first, to read the radiology report and then consult with the radiologist about any findings that were unclear to you. Sometimes skimming the impression or the summary of the radiology report is all that's done, but there's often a lot of, like with the pathology report, very important information can be buried in the report of the main study. And there's really three ways to use this prior imaging. You can glance at it, you can pull it up next to your treatment planning software to aid it in contouring and look back and forth, or you can import it into the treatment planning software to use image registration and create a fusion. So glancing at prior imaging certainly is okay if you're just looking to see whether something was there or not there. Maybe a lymph node that has grown or not grown, or a lung nodule that wasn't there before. Eyeballing the scan, pulling the scan up next to your treatment planning software in different windows is something that we should try to avoid. And the reason being is that it can be very hard to mentally get things aligned when they're on different screens, and you may be missing the fascial planes or the anatomic planes in your treatment planning scan, especially if it doesn't have contrast and it's not registered to that fused image. So of course, registering and fusing the prior imaging, that's the right answer. That was what we would say is best practice and what we always strive for. Now, there's often multiple prior images to exist. So going back to talking about sharpening our axe, we want to have decided, which scans are we actually looking at? Are we looking at pre-op scans, post-operative scans, post-neoadjuvant therapy scans, or multiple of these scans, and which ones are we fusing? And this will differ depending on a thoracic disease site or brain, head and neck, cervix. The answer can be one or both of or multiple of these. So it's important to decide that first. And now coming back to actually going ahead and registering or fusing your prior diagnostic imaging. So again, another issue that we often run into is that patients will get their radiation simulation in a different position than the one that was done in the diagnostic imaging, and it's hard to compare them. So how do we deal with this? This is a problem I deal with a lot, and I'm sure a lot of you do as well. Arms up versus arms down, neck extended or hip rotated where it's not with the R scan. And so what I typically like to do is focus the fusion or the registration and creating the fusion on the area of greatest concern. And you can create multiple fusions if needed. And I prefer to do that over using deformable fusion, which the software vendors are always trying to convince me to use deformable fusion, but I don't trust it. I would rather create multiple fusions. I'm interested to know, Ben, if you feel differently.
No, totally agree.
Yeah.
We here at UCSF, we don't really use deformable fusion.
Yeah. I agree. To someone sitting in a computer programming chair, it makes sense, but it doesn't to me. And so here again on the left, coming back to our nasopharynx case, I've made a fusion where we fused against the skull base and the area where the primary tumor was, and then I contoured the primary tumor, and then I went and modified that fusion to actually reflect better alignment with the low neck. And here we're basing it on the nodal disease. Yeah, great, Ben, thank you. Here we're basing it on the nodal disease, and so now I'll contour my nodes. And so instead of creating two fusions, I've actually just modified one fusion, but you can also just create two if that's easier for your workflow.
So yeah, you could do your base of skull nasopharynx fusion first, and contour all your gross disease, and then later when you're moving on to contouring the nodes, you can adjust to the fusion. So you may have to move things around a little bit to make sure that the nodes line up how you want.
And similarly in the pelvis, this is something you'll run into when the hips are frequently in a different position from your planning CAT scan versus the diagnostic scan. Legs may have been bent or rotated in some way, and so you might want to ignore the hips in part of your fusion so that doesn't throw things off. All right, so next we're going to be talking about expanding our GTVs into CTVs and different ways to approach elective treatment volumes. So again, we're all very familiar with the clinical target volume, and to kind of break it down a little bit more though, there are really three broad categories of clinical target volume or CTV, and they all really have one thing in common, and that's what we're trying to do is treat microscopic or subclinical disease. And so this can include going through these three different categories. We start with direct microscopic extension of the primary tumor, which is not visible in the CAT scan because it appears as normal tissue. You're looking at microscopic disease. And this can be done by creating either an anatomic expansion of a certain size for that disease site. Often it'll be 5 or 10 millimeters on top of a GTV. Or by contouring a whole organ when you're worried about more distant intra-organ spread. And so think about breast or prostate or bladder, where we typically contour the entire organ as a CTV. Another category that we look at are including lymph node regions of at-risk tumor spread. This is sometimes called an elective lymph node volume, especially if no lymph nodes are involved in that area. And these are often described using numbered levels in the head and neck or in the breast, stations in the thorax, or anatomically named regions elsewhere in the body. Third category of CTV is the post-operative treatment volume. And this is often either a tumor bed with an expansion, think about head and neck or brain, or a standardized anatomic region, think about prostate or GYN. And so going through that first category of choosing a GTV, or sorry, a CTV on top of a GTV, again, here we have a nasopharynx case. And what we're doing is choosing a CTV expansion, which is this dark red line, to expand off of the bright red line, which was the GTV. And so the first thing to have known is what size expansion did you want to do? And then the second thing to consider is how are we going to modify that to carve out that CTV from areas that we don't need to treat that are not at risk of tumor invasion. Things like air, as no tumor needs to invade air, and frequently bone, as many tumors don't invade bones. However, it's important to consider that some do, and so you need to account for that, especially in nasopharynx cancer, actually, or some other disease sites. On the other hand, over here, we have some elective nodal volumes, and we can see that I'm treating a pelvis, and this orange line here is my right pelvic nodal basin that I'm contouring. And these are the vessels here. I didn't use contrast for this. And you can see here, I have not expanded my orange CTV into the bowel because the bowel is not a place that's at risk for harboring micrometastatic disease. Whereas over here, we have expanded it further out. Same with the bone in this case, not contouring bone. Of course, this pink line, the PTV, does get expanded into those structures because, as you know, and as we'll talk about again, that's for setup and error margin. And so we don't shrink that off of those boundaries. Now, contouring post-operative volumes, as we mentioned, kind of falls into two flavors. There's the tumor bed with an expansion. Immediately, things that come to mind are head and neck and brain. Here I have a GBM where we're contouring the post-op flare and cavity, and then applying an expansion. In this case, we're carving off the bone here because we're not at risk of having that brain tumor growing into the bone. Alternatively, we have standard anatomic regions that we'll treat for a prostate after a biochemical recurrence or for salvage prostate radiation. Or in this case down here, this is actually a GYN, post-operative GYN treatment where IMRT is being used. And these are standard volumes that are tailored to each patient, but not based on a cavity. So having gone through all of that and how to generate these CTVs, I wanted to discuss a little bit about how to edit CTVs efficiently, because you could certainly spend all night contouring, individually contouring CTV slices on a scan, but there are some ways to make it more efficient. Something that I learned early that I've continued to do and has served me well is that for larger targets, I'll start by completing my GTV and interpolating it, and then expanding the GTV to make my CTV. I'll then go through and delete every other slice through that whole CTV structure. I'll just hit down, delete, down, delete, down, delete, down, delete, down, delete, down, delete, or sorry, down twice, down, delete, down, delete. Don't want to delete the whole thing. Delete every other slice so that you get something that looks like this. And what you'll see is that I've now deleted about every other slice. And so now I can go through and I can trim things off of bone and off of air on every other slice. And then after I'm done, hit interpolate, scroll through and maybe correct a couple of little things here or there where there was a sharp change in anatomy. But in general, this will save a lot of time for manually editing your CTVs. A couple other thoughts on CTVs. We want to be thinking about nodal basins or volumes that are at risk. In general, people tend to think about a 15 to 20% risk of recurrence in an area as being considered enough to want to cover that area with an elective nodal volume. We also want to be recognizing settings where nerve coverage is important because we're worried about perineural invasion. And correctly contouring these nerves is important. This is a great paper in the Red Journal from 2019 from Basque et al. That goes over really in a cookbook-like fashion how to identify all of the nerves that you need to contour on head and neck when you're trying to cover those for involvement. So what about ITVs and PTVs? We're not talking a lot about radiation setup here, but I do think these are important to talk about, even though I'm not going over simulation and hardware and that type of thing too much. Determining your internal target volume to account for motion is important. In the thorax, typically we'll like to use a 4D CT to capture motion, as we showed before. But if we don't have that, that's okay. A lot of places don't have that. You can still treat well without it, but just need to be mindful that you're treating at least an extra 5 millimeters in the craniocaudal or superior inferior directions in the lung to allow for predicted respiratory motion. Similarly, in the pelvis for GYN cases, post-op, you want to sim with, or pre-op, you want to sim with bladder full and empty in order to create an ITV that shows the vaginal cuff or cervix motion and make sure that that's covered as well. So just keeping in mind that for moving targets.
Mm-hmm.
And then
we have a question.
Okay.
We have a question related to that, Dr. Paly. This is from Fanny from Indonesia. In terms of different bladder filling, is it still a good idea to fuse prior image for pelvic malignancies? Let's say if a prior scan had the bladder in a different position compared to your CT.
You could do that as well. So the way that I do pelvic scans for GYN is that I'll actually do the scan twice in the position, one with a full bladder and one with an empty bladder. So I'll start with full bladder, then have the patient scan that, have the patient urinate, scan it again, and then I'll fuse those together. Now, if you don't have access to that, I think a very reasonable thing to do would be to take a diagnostic image where the bladder was either more or less full, and then help use that to create your ITV. Hopefully that answers the question.
Mm-hmm. And if you've taken simulation scans in both positions, then you have two tools to work with for bringing in prior imaging for registration and fusion to make sure that it's guiding you accurately.
Good point, yes.
Great.
So moving on to planning target volume expansion. So our PTV is, again, as this is review for everyone, I'm sure, this is our expansion based on predicted error in daily setup and also in actually the accuracy of your machine. And this depends on what kind of immobilization devices you're using. Head and neck mask or an aquaplast mask obviously holds the head much more reproducibly still than a VacLock bag for the pelvis. And so there's different PTV expansions for those two sites, of course. And then what daily imaging modality you're using, such as a daily cone beam CT, or whether you're doing a weekly port film, will also affect the accuracy. And as I mentioned, the isocentricity of your machine can play into this. So this is really something that is determined with physics, your medical physicist support to understand what's an appropriate PTV expansion, and we don't trim these off of any structure. Some other things to consider, this is a little bit of the miscellaneous stuff, but helpful nonetheless. And that's, what to do when you're uncertain, when you're, worried about what you're drawing or if you're missing something. I like to try to bring those questions to one of these places, which is that I think the tumor board, if you're fortunate to have one, is a great environment to talk to the surgeon and the radiologist about these findings and discuss the areas that are in special need of coverage or at risk. Peer review of contours, if you're fortunate to have colleagues around you that can review your contours, that's always excellent to get a second set of eyes on things as well. Talking to the radiologist one-on-one about anatomy on your simulation scan or on the diagnostic imaging scan can be very helpful if you're uncertain. And then sometimes it's also just good to ask yourself, if you're worried about covering an area or not, how salvageable is a recurrence here? When I'm thinking about, contouring something, certain areas like the presacral space during rectal cancer treatment, or the base of skull for certain head and neck cancers are extremely hard places to salvage a recurrence. And so you might be a little bit more generous in some of those areas while, of course, still respecting normal tissue tolerances. As a completely separate topic, I think it's important to keep your treatment planner in mind, whether that's your medical physicist or a dosimetrist. They do great work for us and are often very overburdened. So important to think about whether we're drawing targets and organs at risk that completely overlap each other. And if so, we should tell them which we want to prioritize and to what degree. And then asking yourself things like, do I really need separate targets if they have the exact same dose? Do both pelvic lymph node stations that are getting the same dose need to be planned separately, or can they be planned together to make things a little bit simpler? Asking yourself, do you really need all of the organs at risk that you've contoured? If you are drawing a larynx cancer, contouring for a larynx cancer, do all of the optic structures really need to be drawn, wasting your time and the dosimetrist time? And then finally, are there any OARs that I didn't draw that I should have to save time for my planner? Something like the brachial plexus often gets forgotten in this scenario. So as we kind of push on towards the end here, this is going to be where we talk about applying contouring tools, resources, and final tips. So thanks for bearing with us. We're on the home stretch here. So, as far as setting yourself up for success, we recommend setting up hotkeys in your treatment planning software. You should use either a brush or a pen, whichever you're comfortable with. Just stick with that one and master it. And then having hotkeys to switch between that, interpolation, filling holes, zooming in and out will all really help with your speed and contouring. And in Eclipse, this can be done pretty easily. If you hit F1 and open up RT and Imaging Online Help and search for a keyword shortcut, you can find these topics. We've also posted here some additional links to shortcuts in Eclipse. This is a nice addition from Ben, which I just learned a good one that I'll be using, which is making a hotkey for filling holes in the axial slice view. I am frequently having to click over to a different slice to fill holes, and so that's a good thing to do. There's also a video here about some of these tips in action, so I encourage you to go back to these. Online contouring resources are incredibly helpful. If you get absolutely nothing else from this lecture and remember nothing else that I said, but you remember to check out econtour.org and haven't seen it before, I would consider your attendance today to have been worthwhile. This is a phenomenal resource, and I really encourage you to check out if you haven't before. It is totally free. You do sign up for it, but it's an interactive atlas, just like looking through your radiation contoured plans, that has everything contoured in it across a variety of different disease sites, or dozens and dozens of different common disease sites and stages. And these have all been contoured by experts using atlases and consensus statements that are standardized documents. So it's not just what some smart person decided should be treated. These are what organizations and international societies have decided how we should contour this case. So I can't emphasize enough that that's been helpful for me. There, of course, are RTOG and NRG atlases. There's a website, RadOnc Review, that I find very helpful, that has a lot of great information on it related to clinical data, but also does include information about treatment planning that discusses boundaries and expansions on contouring. So I encourage that. I subscribe to eAnatomy or imos.com. It's about $100 a year, but it's a great cross-sectional anatomy website that goes through all sorts of different types of images, CAT scan, MRI across the entire body, with very, very detailed annotation of every anatomical part you could ever imagine. There are some additional resources down here for head and neck and CNS. And then, of course, we at RCC have produced some incredible videos under Ben, which I can't recommend enough. And so I'd encourage you to subscribe to the YouTube channel for RCC. You can see several of our past contouring lectures, as well as, of course, the ones that we're producing here as part of this series. I don't know, Ben, any other plugs for the YouTube page?
No, that's great. I'm working on a brachial plexus contouring video. So if you subscribe, you'll get a notification when that one's done.
Other things to keep organized are your consensus statements for contouring. These are very helpful. And so, as you know, cooperative groups, societies, and clinical trials have published atlases and consensus statements that cover the details of contouring many common disease sites. We'll be highlighting these individual atlases and consensus statements as we go through each disease site, and that's the specific lecture. So stay tuned for that, and keep these resources organized in a way that you can reference and get to them quickly. And these are two very miscellaneous final tips from me that I've found helpful. So I think it is worthwhile to invest in a proper mouse for your contouring. I use a gaming mouse here that I purchased on my own. It has a lot of extra buttons, which I'm not using for any online gaming, but is really helpful in the treatment planning software to have hot links to different tools right at your fingertips. You can also unlock the mouse button or the scroll button and in 2 seconds scroll from the top to the bottom of a CAT scan, which is really helpful for me. I think it's also helpful to complete contours in a single session if possible and avoid interruptions. Your mind will be more locked in on what you were thinking if you just stick it out and get through it all at once. Those are kind of my last two miscellaneous pieces of advice. So with that,
Right.
I'll thank you for your attention.